Hi, Linda. Klein here, and I'm going to be presenting my patient care final project for you. We'll start with patient preparation before the day of the exam. Heather's going to call to schedule a time for her IVU and barium enema exams. As the scheduling technologist, I will explain the following preparatory procedures to her. For 48 hours prior to the start of the exam, she must adhere to a low residue diet. For the final 12 hours before the exam, she will have an NPO order, or from at least midnight until the morning of the exam. She will not be able to consume anything, no food, she can't drink anything, no gum chewing, no cigarette smoking, and she can't take any medication. I'll let her know that to avoid nephrotoxicity due to the iodinated contrast media that we use in the IVU, I will need Heather to set up an appointment with our lab to get some blood work done and ensure that her BUN and creatinine levels are within the normal range. If she's had blood work recently, then we can just check her chart and she doesn't have to come in again for that. To avoid any other adverse reactions to the iodine contrast media, I'll need to check her chart and confirm with her that she has no medical history of kidney disease or failure, heart disease, hypertension, and especially diabetes. If she is diabetic, any medication that she takes containing metformin will have to be a part of her NPO order. And she must also refrain from resuming that medication for at least 48 hours after the conclusion of the exam. Other relevant pieces of information to obtain as part of her pre-contrast history. Has she had any contrast exams in the last 48 hours? Does she have any history of allergies or asthma? Has she ever had a contrast study done before and had an adverse reaction? Is she currently taking any beta blockers or antihypertensive medications? The next part will be me explaining that we need to have her bowels really flushed and clean for the exam to work properly. So she'll have to take a laxative the night before her exam day. There's two classes of laxative usually recommended, irritant and saline, with saline being the preferred type, like a magnesium citrate or a magnesium sulfate will probably be prescribed. And in addition to the laxative, a cleansing enema might be ordered. She can do this at home the day before, the morning before her exam, or she can come to the clinic and we can do that for her. It's not everyone's cup of tea, but these things are essential to the success of the barium enema. I will recommend to Heather that on the day that she comes in to not wear any jewelry or body piercings because we're just going to have her take those all off. In addition to wear some loose-fitting, comfortable clothing because she's going to have to take that off anyway and change into a gown for both procedures. As for the actual scheduling of the time of the exam, I will set it in the morning generally because that is what works best with NPO orders. I will also let Heather know that she needs to sign an informed consent form on the day of her exam after I explain everything to her, confirming that she understands the risks and possible side effects of the procedures. So on the day of the exam, before Heather arrives, I'll double check her chart just to confirm what kind of NPO orders she's been given, if she has any medication that she needs to cease from taking. And when she gets there, I'll greet her with the standard, hi, my name's Klein. I'll be your technologist today. Ask her for those dual patient identifiers. Inquire about pregnancy. And ask her why she is here for these exams today. If it's some chronic condition or if this is an acute problem that just came up recently, how long has she been in pain? If she is in pain, where is it? What is the quality of her pain? All that fun AIDED stuff. And then I'll follow up about those specific prep items, the low residue diet, make sure that she's followed the NPO order, that she's taken a laxative, that she's had a cleansing enema. And then I'll run through her chart to confirm those pre-contrast history details, the BUN, the creatinine levels, history of medication, history of kidney or heart problems, allergies, if she's asthmatic or diabetic, if she's had a contrast exam in the last 48 hours, if she's had a reaction to contrast media in the past. because maybe I'm not the scheduling radiologist. It's always good to double check these things just to make sure. And if she does have a history of any kidney heart problems, allergies, asthma, reaction to contrast media in the past, I should put a note in her chart. She might be at higher risk for having a reaction today when we do the IVU. And then I will run through with Heather the procedure for the IVU and the barium enema. We're going to start you with an IVU today. It's going to help us check your kidney urinary system function, and will involve an IV injection of iodinated contrast media. This can sometimes make people feel flushed, weird taste in their mouth, totally normal symptoms to having this kind of stuff injected, and those symptoms should pass within a minute or two. Just kind of let her know that those are very common reactions. It should take about an hour. You'll probably be lying on your back for the majority of the exam, and it's going to be so that the radiologist can take a look at the dynamic movement of the contrast medium through your urinary system, the kidneys, the ureters, and the bladder, and that I'm going to be taking several still images before, during, and after the exam as well. And then after we finish the IVU, we're going to move on to the barium enema. This is going to involve an enema tip inserted into the rectum so that we can inject a barium water mixture to better see the functioning of your lower intestine. This is going to be slightly more uncomfortable than the IVU for obvious reasons, but the exam should still only take about an hour. You're going to be lying on your stomach a lot during this exam, and the radiologist is going to ask you to change your position, your body position, and rotate you around a little bit more than during the IVU, because we really need to get the barium to coat your entire large intestine, so you kind of have to move around a little bit more. There might also include introducing air with the barium to get it to kind of stick to the walls of the intestine. That can cause bloating, make you feel uncomfortable. But we'll try to get it done as quickly as we can. This exam also going to have me taking some still pictures before, during, and after, and the radiologist is going to be looking at those dynamic images throughout the study. After I explain all this to Heather and ask her if she has any questions, I will ask her to sign the informed consent form. I will then ask her to go to the bathroom and empty her bladder, that's mostly for the IVU, and evacuate her bowels if she still needs to do that for the barium enema. I will give her a gown to change into, tell her to, remove any body piercings, jewelry, and remove, clothes, underwear, bra, all that fun stuff, and probably her shoes as well, in which case I'll give her some booties to wear. No one wants to walk around the hospital barefoot. So before I bring Heather into the exam room after she's changed, I will have prepped it fully, and there's some things that both exams are going to need, and that is making sure the fluoro tube is on, set to fluoro mode, it's clean, it's ready to take images. I'll have all my cassettes ready if we have a separate overhead unit for taking spot radiographs, and any plastic coverings that I might need for those cassettes in the case of the barium enema. And I'll have the fluoro table set into the horizontal position, make sure the lead curtain and Bucky slot cover are in place, have the Bucky tray at the foot of the table, and just have everything set up nicely for the radiologist, have that foot control pedal and the viewing monitors right where they need them during the exam. I'll set aside all the proper lead shielding that may be needed by the radiologist, myself, or any other person who might be needed in the exam room. So, your lead aprons, glasses, thyroid shields, and especially those lead gloves for the radiologist. And I'll also have lead numbers, minute marker, and those left and right indicator markers for the spot radiographs. And to make sure the room is ready for the IVU, there's a bunch of specific things that need to be prepped, mostly pertaining to the IV tray and the injection procedure. So we'll need to have the correct type and volume of water-soluble, non-ionic, iodinated contrast medium needed for the exam, drawn into the syringe, ready to go. Commonly used contrasts for IVU are Omnipaque 300 or 350, IsoVu 300, or Visipaque 320. I'll have the bottle of the contrast used in the syringe on the tray with the label visible for the radiologist to inspect to make sure, double check I did the right contrast medium. I'll have a selection of sterile needles between 18 and 22 gauge for an IVU, and either an over the needle catheter or a butterfly type needle with all the appropriate tubing. I'll have all the necessary equipment and accessories for the injection procedure: gloves, alcohol swabs, saline solution to flush out the tube, tape, gauze, band-aids, tourniquet, sharps container, and a towel or maybe a sponge to support Heather's elbow while I do the injection. I'll also have male gonadal shielding and a uteric compression device if they use one in the department. And I'll have an emesis basin or, a similar waste container of some kind, a cold towel for her forehead / injection site if it gets swollen, and a warm towel too, because who doesn't like a nice warm towel? And I'll also make sure that oxygen and suction equipment is operational and accessible and has, all the proper masks in case she has a really bad allergic reaction. Also, in case of a bad allergic reaction, I should make sure that the crash cart is fully stocked and ready to go, and that there's epinephrine and Benadryl ready to be injected in case of an emergency. And I'll just run through the radiographs that we typically do for an IVU. So after Heather's injected, before Heather is injected, we'll do the scout radiograph. This is basically a KUB, and it's just to determine patient preparation, make sure her bladder is voided, make sure our technical factors are on point, our positioning is good, and to detect any abnormal calcifications that might be visible without contrast medium. The SID is going to be 40 inches on a 14 by 17 lengthwise cassette, collimated to the size of the IR, 80 to 85 kVp, with a perpendicular CR centered to the iliac crest right at the MSP. She's going to be supine on the table, head supported with a pillow, arms at sides slightly abducted, with a sponge under the knees for support. And the breathing instructions for this and every single image that we are going to take during these two studies is suspended at expiration, because we need to get that diaphragm up and out of the way so we can see the abdomen as clearly as possible. This AP position, this AP supine, is going to be used more than once during the IVU, not just for the scout. And it's good for signs of obstruction, hydronephrosis, tumor, or infection. All right, we will also be taking a nephrotomogram. This projection is obtained to demonstrate any pathologies of or trauma to the renal parenchyma, the kidney tissue. 40-inch SID again. This is going to be 14 by 17 crosswise, collimated down to 11 by 14 because we're just looking at those kidneys. 80 to 85 kVp. And we're going to use a 10-degree caudate angle, and we're going to center that right between the xiphoid process and the iliac crest at the mid-sagittal plane. Same position as before, supine, head supported, arms at sides, sponge under the knees for support, and suspended expiration. We're also going to be doing an RPO and an LPO. And these are helpful when trying to visualize the kidney or ureter on only one side of the abdomen. Whichever one is closest to the IR is the one that's going to be best demonstrated. So the RPO for the right kidney, LPO for the left kidney. 40-inch SID, 14 by 17 lengthwise cassette, collimated to the anatomy of interest. We can maybe bring in the sides a little bit. Technique 80 to 85 kVp. And we're going to be centered right on that iliac crest again, smack in the middle of the vertebral column. And we're going to do 30 degrees of oblique from the table. We can use a sponge to support. Have that elevated knee flexed, the elevated arm placed across the upper chest, and the other arm down to the patient's side. That's standard LPO, RPO positioning. And we're also going to do a post-void. So after the patient has voided their bladder at the end of the exam, this projection can demonstrate an enlarged prostate or a prolapse of the bladder. And we can do this prone or erect, and the erect is going to demonstrate abnormal positioning of the kidneys, like if they've shifted around in the abdomen at all. Again, 40-inch SID, 14 by 17 lengthwise, collimate to the size of the IR, 80 to 85 kVp, and that CR is going to be at the iliac crest and MSP again. And we might want to go maybe a little bit lower for older men, just to make sure that you get that whole pubic symphysis prostate area. For the AP erect, arms slightly abducted, feet slightly apart. For the prone, arms raised above the head, up on the pillow. And again, suspended at expiration for those breathing instructions. Okay, so assuming that went well, let's talk about the barium enema now. There's some extra stuff we need to prep for the room for this exam. We need an IV stand, or the stand for the barium bag, ready to be 24 to 36 inches above the table. That might vary if the radiologist wants more or less flow. We need the enema bag. We need the tubing. We need the tip. We need lubricant for the tip. There's several different types. We might be doing it double contrast, so we'll make sure we have that tip with the extra air tube, and also the gas tank that we would need to supply that air. Usually it's CO2. And we'll have thin and thick barium ready to be mixed. Thin usually for single contrast, thick for the double. We'll have our source of tepid water ready to make that barium mixture. And we'll have towels, tissues, waste container, bedpan, extra sheets, extra gowns, and appropriate waterproof covering for the fluoro table in case there's a premature evacuation of the barium, and an air freshener. And so we'll just run through some of these positions that we might be doing for our spot radiographs during the enema. We can do an AP or a PA. For this first position. For a single contrast study, this position best demonstrates bowel obstructions, such as ileus, volvulus, intussusception. Double contrast studies are ideal for showing mucosal changes, polyps, and diverticulosis. SID, 40 inches, 14 by 17 lengthwise, collimated to the size of the IR. And our technique is going to be different depending on what contrast medium we're using. We're going to use a higher KVP of 110 to 125 for single contrast, because that's the most dense. 90 to 100 for double contrast, because of that air. And 80 to 90 for water-soluble iodinated contrast. And this is, just like before, it's a basic KUB. You're going to be centered at that iliac crest and MSP with the CR. So this is prone or supine, depending on if it's a PA or AP. Pillow for the head, arms slightly away from the sides or placed above the head, and like all our positions, suspended at expiration. And I split these up into the RAO and LPO, because these are the oblique positions that are going to best demonstrate that right colic flexure open and free of superimposition. Same SID, another 14 by 17 lengthwise IR, collimated to the size of the IR, with those same technical factors for the different contrast medium. The CR is going to be directed to the iliac crest and then just 1 inch to the left of the MSP, so we make sure we don't cut off that right colic flexure. The patient position for the RAO is going to be prone, with the body rotated 35 to 45 degrees. Use a sponge to support them. That left arm flexed and placed on a pillow, and the right arm down at their side, partially flexed left knee. The LPO is going to be supine with their body rotated 35 to 40, with their left arm at their side, their right arm flexed and placed across the chest, and that right knee partially flexed to help maintain the position. And if we want to see the left colic flexure, we're going to do an LAO or an RPO to get that flexure nice and open. Same SID, same IR, same collimation, same technique. And for this one, the CR is going to be 1 to 2 inches above the iliac crest instead of right on it, because that left colic flexure is the highest part of the large intestine, and we want to make sure that we don't cut it off. And then we're going to center horizontally 1 inch to the right of that mid-sagittal plane. For the LAO, the patient's going to be prone, same body rotation, 35 to 40 degrees, use a sponge. Left arm at their side, right arm up on the pillow, right knee partially flexed. The RPO, supine, same rotation, 35 to 40 degrees, with that left arm flexed, placed across the chest, the right arm at their side, and a partially flexed left knee to help maintain their position. And, of course, suspended on expiration for those breathing instructions. Now we get into our lateral images. These are going to help demonstrate polyps, strictures, fistulas between the rectum and the bladder/uterus. The ventral decubitus lateral is mostly used for double contrast studies. So this is going to be a 40-inch SID. We're going to use a 10 by 12 lengthwise cassette. We're going to collimate to the size of the IR. And we're going to use 110 to 125 kVp. The CR is going to be perpendicular, centered at the as-is and the mid-coronal plane, midway between the as-is and the posterior sacrum. The patient positioning for the lateral, just the patient in standard left lateral position, sponge between slightly flexed knees, head on pillow and elbows flexed and with the hands drawn up above the head in the shark fin. And the ventral decubitus is going to be a prone, head on pillow, hands above the head, the IR placed on the patient's left side. We can also do either a right or a left lateral decubitus. These lateral decubitus projections, these can be done AP or PA. These lateral decubitus projections are especially helpful for visualizing polyps, of the large intestine, and are generally only used in double contrast studies. They can be performed either AP or PA. SID is 40. We're going to use a 14 by 17 lengthwise with that nice cassette grid over the top. Collimate to the size of the IR. Technique, we're going to do 90 to 100 kVp. Our CR is going to be perpendicular, directed horizontally, right at the iliac crest and the MSP, just like the other KUB projections. And the patient positioning, either left or right lateral position, with sponge in between slightly flexed knees, hands together and placed above head. Use a pillow. We also have some axial projections we can use. These projections will help demonstrate any polyps or pathologies in the sigmoid colon. So we're going to use a 40-inch SID, a 14 by 17 lengthwise cassette, and we're going to collimate down to 11 by 14 because we're really only interested in that sigmoid colon, not the whole abdomen. And we're going to have those similar kVp ranges for the different contrast medium, 110 to 125 for single, 90 to 100 for double, 80 to 90 for water soluble. Our CR is going to be angled 30 to 40 degrees cephalic. And for the AP axial, we're going to center 2 inches inferior to the as-is, right at the mid-sagittal plane. And for the LPO, we're going to do 2 inches inferior to the as-is, and then 2 inches medial of that right as-is, that elevated side. The patient position supine with head on pillow, arms slightly abducted at side and support under knees for the AP axial. And for the LPO, we're going to rotate the patient 30 to 40 degrees, help them with a sponge, left arm at their side, right arm crossed across the upper chest, and the right knee is partially flexed. And we can also do a PA version of those two projections. You can do a PA axial or a PA axial oblique, which is an RAO. Again, it's to demonstrate polyps or pathologies in the sigmoid colon. So, same SID, 40. We're going to collimate down to 11 by 14 and a 14 by 17 lengthwise cassette. Same technical factors, depending on what contrast we're using. 30 to 40 degree caudad angle on the CR this time. And for the PA axial, we're going to go at the level of the as-is and the mid-sagittal plane for our centering point. And for the RAO, we're going to go at the level of the as-is and 2 inches to the left of the lumbar spinous process. For the PA, the patient's going to be prone, head on pillow, arms raised up and placed on the pillow. And for the RAO, the patient is going to be rotated 35 to 45 degrees using a sponge, with their left arm up, right arm slightly abducted at the side, and the left knee partially flexed. And suspended expiration, of course. And this should be our last projection because it's going to be a post-evacuation PA or AP. And it's going to demonstrate the mucosal pattern of the large intestine, and it's useful for polyps and other abnormality visualization. It's usually done PA, but it can also be done AP if you need. And this should be the last one you take because this is going to be after you've removed the enema tip and the patient has been taken to the bathroom and had a chance to evacuate their bowels. So we're really just looking at the little bit of residue of barium left in their colon. So 40-inch SID again. We're going to be using a 14 by 17 lengthwise cassette. Collimate to the size of the IR. And we're going to use 90 to 100 kVp and use a post-evacuation marker so that we know that this is a post-void image, kind of similar to how we would use those markers for the beginning of the IVU. This is the pre-void, the scout image, that kind of stuff. Good to have that marked. The technique may even be slightly lower than this, depending on what our images look like. Because they've lost so much barium, there's going to be less bouncing back, so we might even go down to 80 kVp. So either prone or supine with a pillow for the head for our patient positioning, arms slightly abducted at sides for the AP, or bent and placed up near the head for the PA. All right. So that was our theoretical exam. Let's get back to this actual exam that we're set up to do with Heather. So I've explained everything to her, ran through the exams. She's changed, ready to go, meets me in the room. She signed the consent form, and the radiologist gives me the go-ahead to start her IV. So I begin by performing hand hygiene and putting on fresh gloves. I have Heather sit down and have her support her right arm on a table. She tells me that she's had IVs before and they usually go for the right arm, so I assume that's where the good veins are. I'll take her word for it. And so I want to select a vein next. For an IVU, I want to go for a vein in the antecubital fossa, the basilic, the cephalic, or the median cubital. Those are generally going to be the best. And after just briefly feeling around with my index and middle finger, I can really feel her median cubital nicely, so I decide I'm going to use that one for the venipuncture. So I tie a tourniquet about 3 to 4 inches above that vein, and then I take an alcohol swab, and I disinfect the injection site by rubbing in a circular motion from the center outward for at least 30 seconds. I toss that swab and wait for the alcohol to dry a little bit, couple seconds is all it takes. And then I take my non-dominant hand and anchor the vein about an inch below my chosen injection site, and just kind of stretch the skin just a little bit, just so I can really present that vein nicely. With my dominant hand, I pick up the 20 gauge butterfly needle that I've selected, and I fold up those flaps so I can have a nice secure grip. With the bevel of the needle facing upward, I then advance the needle quickly and carefully into that vein at a 25 to 45 degree angle. And once I see the flashback, that little bit of blood going into the tube, I lower the angle of the needle so it's more parallel with the vein as I just slide it securely into place. I then retract the needle and attach the IV tubing to the butterfly hub, and I tape and I take those two wings, place them down against her skin, and tape them into place. At this point, I will remove the tourniquet. So I will toss the needle in the sharps container, and now we are ready to start with the injection of the contrast media. I make sure the IV line is flushed with 5 to 10 milliliters of normal saline. Then I attach the syringe, and I fully depress the plunger of the syringe over about 30 to 60 seconds at most. This is a bolus injection. We want to get all that contrast in there really quickly. And that'll complete the injection. While I'm doing this, I want to be really carefully watching that injection site to make sure that all of it's going into the vein and we're not getting an extravasation. So the injection went smoothly, and I now record the following items in Heather's chart. The starting time of the injection, the type and amount of contrast that I used, how Heather reacted during the procedure, her demeanor, whatnot, and any other information that might be needed as per departmental rules or policy, like what type of syringe did I use, that kind of thing. So, unfortunately, Heather begins to have a reaction to the contrast media. She's tasting something funny. Doesn't feel good. She's kind of nauseous. But these are a common reaction to contrast media. So I tell her that it's not a big deal. I reassure her that these symptoms are very common, and that they normally pass within a few minutes as the body acclimates to the contrast. Just in case her nausea gets worse, I make sure to have some tissues at the ready and make sure that waste receptacle in the room is nearby just in case she has to vomit. But, this is, a standard reaction, so not a huge deal. Business as usual. Unfortunately, Heather's reaction worsens. After 10 minutes of the injection, I get ready to do the 10-minute KUB. And I noticed that she has red spots on her face, and she's getting a little flush. She looks red. And these are indicative of an intermediate reaction. That erythema, that redness of the skin, the urticaria, hives. And since her reaction appears to be getting worse, I immediately notify the radiologist. I tell Heather that, these are not serious symptoms, but it is just an elevated reaction to the contrast media. And I've got a shot of Benadryl ready to be administered by the radiologist. This should quickly alleviate her symptoms if they do not begin to resolve soon. And I don't tell Heather this, but I make sure that there's a shot of epinephrine ready to go if the radiologist also wants that in addition to the Benadryl to try and help Heather out with this reaction. At this point, I'm now really closely paying attention to Heather and making sure that her reaction does not get any worse. I want to really be really watching her carefully now. Unfortunately, Heather's reaction becomes severe. The radiologist does get here, but it takes him about 10 minutes, so it's been about 20 minutes since the initial injection, and Heather's now short of breath. She's feeling tightness in her throat, and her face is visibly swollen. And these are signs of a severe reaction to an iodinated contrast media. Bronchospasm, dyspnea, swollen face. These are typical symptoms of someone who's going into or is in anaphylactic shock. The bronchospasm is not a huge deal. Technically, that is an intermediate symptom, but combined with her difficulty breathing and the swollen face, that I know that means this is an anaphylactic reaction. This is not good. This is severe. If she's not treated immediately, she might go into respiratory or even cardiac arrest. So I move Heather into a dorsal recumbent position with her feet slightly elevated, as well as her head slightly elevated, because that's going to help her breathing. And in addition to the epinephrine that we've got on the tray, I go to the crash cart and make sure that we have a syringe of atropine that's ready to go as well if the radiologist needs it. And I'm also making sure that the oxygen tank is ready to go with a nice high flow mask if the radiologist feels that Heather needs to start receiving supplemental oxygen, because she just can't get enough in right now because of her swollen, constricted throat. At this point, the code team has arrived. The doctor calls the code team in because he sees that this is a bad reaction. And the best way for me to be useful in this situation is just to kind of make sure that they have room to do their job. Get any equipment out of the exam is not a priority anymore. We need to get anything out of the way that is not going to be about treating Heather's allergic reaction symptoms. And maybe the code team needs to know, when did this happen? How long has it been since she was injected? What did you inject her with? What is the progression of her symptoms? And I need to be ready to give really detailed, accurate responses so that they can treat her accordingly. Since I did the pre-exam evaluation, it's all still in my head. I can also answer any questions they might have about her relevant medical history, so someone doesn't have to be looking through her chart to see if she's allergic to something. I can have that information ready to go for them. Once I've answered all their questions and, given them all the information they need, then they're going to take her off to the emergency department, and my job is done. And, hopefully Heather has a speedy recovery, and we'll reschedule her barium enema for a later date, after she's recovered, because that is not her health is our primary concern, not her barium enema procedure. And, take a deep breath. My job's over, and it's a good thing that I knew a lot about how to treat a severe contrast reaction and how to respond to one before experience the situation firsthand like I just did. Knowing that I'm prepared and did everything I was supposed to will help me not feel guilty that maybe, I could have done something, I missed a sign, or I should have known earlier that this was going to be bad. And it's no, because I knew what to do, I know that Heather got the best treatment she could have possibly had. And that's, at the end of the day, that's what we want as radiologists. We want our patients to be healthy. So yeah, I really liked this assignment, and it took a long time. It was really tedious putting all these slides together, but it never at any point felt unnecessary. This is all really, really good stuff to know. And because I do not want to have a panic attack or be all jittery and, screw something up if a reaction like this actually takes place while I'm out there as a tech. So thanks, Linda. I really liked this assignment. It was really good. And I'm super glad that you asked so many thorough questions for this final project. And yeah, I loved being a student of yours. You were a great teacher, and I learned a bunch. And I'm sad that this is our last, interaction as a teacher and student. I had a great time in your class, and yeah, I hope you have a great Christmas break.